Today's discussion will be something to do with the impact of the recession or the socioeconomic downturn that we're facing at present and how it's affecting our healthcare system as a whole and how it's affecting individuals that I see in my family practice in Richmond Hill. All of us realize Richmond Hill as a dominant Indo-Caribbean community with its own sets of problems that we're faced with in terms of disease processes and of hypertension, diabetes, high cholesterol, coronary artery disease, cigarette smoking, alcohol abuse, and also the exacerbation of drug abuse that's occurring at this stage. My role today is not to define in specific medical terms some of the problems we're faced with, but to give you an idea of some of the things I happen to be fortunate to see as a physician, but which I think has such a far-reaching consequence on our behavior that I see it's also affecting the physical well-being of our children and our parents. For instance, if you walk on the avenue on, say, a Friday, I've never seen longer lines of people lining up and waiting for handouts. I have never seen longer lines of persons coming to the office for pregnancy tests, especially teenage pregnancies. I have not in my years of practice in Richmond Hill seen the complications of chronic and acute alcoholism as I'm seeing now. I have not seen so many persons requesting medications for helping them to sleep. I have not seen so many persons who come with uncontrolled hypertension and diabetes who were previously well controlled. Some of these and the impact of it, when you discuss it, and being in a privileged position to discuss personal matters with patients, it makes me feel very, very sorry that we were not able to impact on this at an earlier stage than at this point in time. All of us are assured that we will try the best we can to get out of this recession as we started, both in terms of keeping our homes, keeping our jobs, keeping our families, and keeping our health status the way it was before. But it has gone on for so long that the impact of it and the chronicity of it is starting to reveal itself in the complications of medical illnesses. I'm seeing more patients presenting with depression, more patients who are asking now for medication for depression. Doctor, can I have something to get out of this mood? I am depressed. I'm about to lose my house. My husband started back drinking. My children do not come home any longer. My daughter has moved out and has gone to live in a basement with someone else. And a lot of the similar stories that you hear on a daily basis. As part of a community, I feel partially responsible that we as professionals should have been able to help to contribute an impact on the severity at which people have had to deal with some of the losses. I think the religious community as a whole should have also been able to be more proactive in addressing these situations. As a physician, I also feel that I also should have warned my patients ahead of time that with depression comes myriads of other disease processes. Worst of it is the worsening of your diabetes, your hypertension, paying less attention to yourselves, becoming more obese because you cannot afford to exercise because you're working for so long hours. You take solace in food, and sometimes the food we tend to eat are sweets and carbohydrates. We worsen our obesity. So some of these things that we're faced with as a result of the recession that's taking place, that's impacting on our general health, and is also impacting our family lives, is not something that we should have not been well prepared for, but at least we should have been able to deal with it at a better level. I should have been in a position as a physician to offer counseling to my patients at an earlier stage. We should also be able to equip the churches, the mandirs, the mosque, or the religious organizations to have more open houses in terms of patients or congregations coming in and discussing their problems at an earlier stage. I have seen larger number of families that have become disjointed as a result of the socioeconomic impact of the downturn. My message today is if we can actually, at least at a later stage, even today, it's not too late, for us to collectively as a community, with the professionals, the churches, and other organizations, try and reach out to as many as possible. We will try in our own way to see if we can actually start a drive or assist in a drive that's already been started by others to make the impact of the recession in terms of trying to provide some of the material things that people need. But it goes beyond the material things. The churches and the religious organizations, we owe it to our community to at least make ourselves more available for counseling sessions. As a physician, I need to make my office more available to those patients who are working late hours, for those patients who cannot afford medications, for those patients who are asking for something to be done and not having the money to pay for it at that point in time, be able to afford them the services. It has come to a stage where we need to reach out to each other as a community and basically address these issues. We need to look outside of the box of ourselves as professionals, as persons with different professions and different skills and different abilities to help in order that we can ride out this recession. But I think as a community, we are faced with issues. And unless we can see what we as individuals and ourselves as organizations can do for this community, I think we will go a far way in impacting the disease process that seems to be getting worse in our community, the socioeconomic burdens of our community that have resulted in increased use of drugs, alcohol, cigarette smoking, and domestic violence. I will try and address some of these issues at a later date. Thank you. That's all for now. Good day, viewers. Our discussion today will be on trying to save money in our present healthcare system. I do not claim to be an expert in healthcare management, but I've been a physician for 25 years. I have practiced in first world and third world countries. I've practiced in affluent societies and poorer societies. I've practiced in indigent groups and also immigrant groups. I've practiced medicine uninterrupted, and thank God for that, for 25 years, with hardly ever a break for more than a week at any point in time over those 25 years. And throughout those days, it's usually been 7 days per week. Over the latter 3 to 5 years, it's been more or less 6 days per week, but averaging like 18 hours per day interacting with patients. It does make me some bit of an expert in terms of patient care, or at least being able to evaluate a little bit more in depth based on the duration of time that I've spent in medicine. And also because of the fact that I've ran emergency rooms, I've admitted patients to hospitals, I've done home care, and I've also run my own private practice over the last 15 years in Richmond Hill in Queens. So I feel as if, having done the wrongs as a physician in the emergency room, as also in intensive care, and also in some of the best institutions, Jackson Memorial Hospital at University of Miami, and maybe some of the not so great institutions in New York, I find myself in a position that if I can be allowed to comment to the situation, I think it's just my viewpoint on what I think are ways and means we can save on the amount of money that's being spent on health care, and some of it that's unnecessary money that's being spent that's causing the health care budget to go beyond what the the required amount and beyond what other countries with similar health care, or even sometimes health care on par with our health care system, have actually been able to do and be able to control their budget. Our President, Barack Obama, has been trying extremely hard to try and get bills passed so at least we can save money in health care and allocate that money to elsewhere. At no point in time is it ever meant that we should compromise our healthcare system, which at this point in time is always being taken for granted as being the best system in the world. But I think in addition to being the best system in the world, it's also the most expensive system in the world. And I think we can still keep the best system in the world and decrease the expenses by looking at some of the ways and means that we're spending an extraordinary amount of money, and we can save on that money without compromising on patient care. For instance, if we look at the number of tests that we order, like MRIs and CAT scans and PET scans, that literally cost a tremendous amount of money. There are particular indications for the ordering of these tests. There are particular reasons why these tests should be ordered and to what benefit it is for the patient. There are a lot of patients who will benefit from having it done. Those patients should not be denied that. But when it comes to a case in which an MRI is ordered for a whiplash injury to the neck when there's no neurologic deficit, makes us wonder as to why we're ordering that MRI. Because we don't plan any surgery, there's no neurologic deficit. Are we trying to rule out whether or not there's a fracture? The patient is in mild pain from most likely muscle spasms. Let's, for instance, say we're ordering a CT scan of the abdomen with contrast. That costs a tremendous amount of money. Are we ordering it because we cannot find out why a patient is having a belly pain, which could easily be settled by possibly monitoring that pain because it's not an acute situation, but because the patient complains on 2 or 3 occasions and we are afraid of the malpractice situation, we order a very expensive test that will end up costing the insurance carrier probably between $1,500 to $2,000, as opposed to just 2 to 3 office visits of $20 to $30 and monitoring that patient's abdomen and condition. We could probably get the same result because it comes back as negative. And how often have we not seen these expensive tests come back as negative? Or how often have we not seen that is not enough information? I am not one who's going to tell you that I'm in favor of registered nurses telling me what test is appropriate. But I think as physicians, we know what is happening in healthcare, the healthcare industry. We know how it affects the rest of the community. We know how hard the government is trying to contain the cost of healthcare, so we can at least, as we get older, have some entitlement to whatever medical benefits we've paid into, so we are also the beneficiary. But also our kids are going to be the beneficiary of this eventually if we are able to contain health care. So by limiting those number of tests, we can do that as well. We can do it also in addition to that by trying to triage what we consider as being emergency, urgency, or just plain mundane treatment of something that has been allowed to go on because that patient was unable to see the physician. Obviously, we can actually make sure that some things that are urgent, that emergencies, the gunshot wound, the acute abdomen, the chest pain, the shortness of breath, are triaged to institutions that are able to deal with it as an emergency with the proper team in place. And we have, in addition to that, 3 or 4 tertiary institutions that are able to deal with the urgencies. Example, the patient with the bronchitis, the patient with a stable angina, the patient who has got the belly pain, vomiting, and diarrhea, but feel unwell. We also have those situations in which the patients coming from nursing home with chronic decubitus ulcers could be dealt with not as an urgency, but once they're stable, at a lesser institution that are capable of managing those, but are not compromising the emergencies. The emergencies are the ones when a patient dies, create the headlines, and cause the politicians and the healthcare individuals to also get into a frenzy and request that their institution be given all the upgraded medical equipment that sometimes are not necessary and sometimes are in a neighboring hospital less than half a mile away. If we're able to contain where tests are given, if we're able to triage patients from the ones at emergency to urgency to the ones that can actually wait before they're seen, we will actually end up saving a tremendous amount of money. Because obviously the tertiary institutions, the ones that have the state-of-the-art equipment, will be the ones we send our most ill patients and our patients at risk for dying. That is one of the ways we can save money. So we can save money both in terms of the testing we do and the places where testing are done and the indications for having testing done, and be very strict in the guidelines of having it done, but also be respectful to the physician who's afraid of the litigation associated with it because he did not have it done. We also can save from what I mentioned before, triaging. Try and make sure that there's institutions that are geared for urgent and emergency and able to give medications for patients in a heart attack who are having an impending heart attack and actually save that person from having a bypass surgery, or actually being able to treat an acute abdomen before it becomes a ruptured appendix or a ruptured viscus and resulting in more emergency, more days spent in hospital. So these are some of the ways, and I'll continue this discussion in the following topic, in terms of other ways and means we can try and save money in the healthcare system. I cannot quantify it, but I can at least tell you where it is I see in my 25 years of practice that we're losing a tremendous amount of money in the healthcare industry. Thank you, and that's all for now. We will continue a discussion on ways and means we can save in the healthcare industry. I'm not claiming to be an expert, but having practiced medicine for 25 years in different communities and in different patient settings, and from the emergency room to nursing homes to intensive care and my own family practice, I feel I do have a contribution to make in terms of some of the ways and means I think we can save. I did mention in a previous discussion where by simply being able to triage patients, we can change our institutions. For instance, if we have 4 hospitals in a very narrow catchment area of 3 miles radius, we can make those institutions, one, a tertiary institution that has state-of-the-art equipment for managing all emergencies, whether it be an acute abdomen, recent onset of chest pain, a person who's presenting with a stroke for the first time, a gunshot wound, a ruptured viscus, a fractured limb, or a person who is at risk for dying or increased morbidity as a result of a disease process that we need the best care possible. We also do not need to make all 4 of those hospitals so close to each other, being able to have a PET scan and an MRI machine and expensive equipment, not only the equipment per se, but the cost of maintaining that equipment, the personnel responsible for those equipment, etc. We can triage our healthcare system in such a way that we're able to deal with that, and the ambulance drivers, as well as the persons who are referring those patients for admissions, can actually be able to direct them to the institution. I know in Florida, we had Jackson Memorial Hospital as being the tertiary institution at which we were able to treat gunshot wounds, we were able to treat ruptured viscus, patients who are coning straight from the rooftop of the hospital right into the emergency room, and being able to give the best possible care. I know ambulances actually took gunshot wounds from South Florida right into the emergency room in less than 10-15 minutes. I know that's the level of care that we should be trying to achieve, but it's not easy as just saying it. It has to be a system in place. But I also know that there's some certain institutions that could just be able to take care of the common things that take a long time, but also create our chronically ill parents with the bed sores, who's now having pain and probably a little bit dehydrated. Obviously, sometimes we need to take them to another institution that is better able to take care of those chronic conditions without jeopardizing the life and longevity of our parents and other relatives in different conditions, which is already established as chronic condition. I don't want to be controversial on a topic that I'm not an expert in, but I still think that we should be able to divide in terms of patients who have an established chronic illness that we do not expect them to recover from, but we expect them to be comfortable as they approach the end of their lives, as opposed to the person who has just had an incident that is totally reversible if we act promptly. Being able to put hospitals in those positions will help us to save tremendously, because we are able to allocate our resources much more to that institution which has the experts and the ability to render the best possible care. We do not need all the institutions in that 3-mile radius, all 4 hospitals for argument's sake, to have all the equipment that are needed. But we need to be able to say, you specialize in the emergency, you specialize in the urgent care, you will specialize in the chronic care. And we can actually be able to save money by actually being able to triage this and be more efficient at managing our patients and getting a better outcome of our illnesses, at least making our patients happier, the relatives happier, and saving money in addition. I also mentioned the fact of other things that we can do to try and save on health care. We have to be able to identify end-of-life issues. Those end-of-life issues that end up in the intensive care that cost a tremendous amount of money, that we know do not have a positive outcome. Even how much I will love my parents when they approach the end of their life, once it was established that they had advanced cancer that had already spread, and you know the life expectancy, even how much best care you're given, will not increase by more than about 6 weeks to 6 months, you do not make it mandatory that that person be admitted to intensive care at all times. Obviously, if it's a reversible condition, the physician on site will have to make that decision. But there should be rules in place that actually make it an even playing field, where patients that have a positive outcome as something that's totally reversible and able to get back to the workforce should be given that priority. The younger individuals who basically with a reversible illness should be actually, there must be something that someone who is qualified enough, and I'm not saying I am qualified enough to make that decision, that that person's condition warrants them getting intensive care. I know we have it in the hospitals in place, but I know it's something that's so sensitive to address at all forums that sometimes even the hospitals are afraid to discuss it. And even when you go to meetings to try and discuss ways and means of saving money on health care, it becomes a very, very touchy issue in terms of who is deciding whose parent it is going to be taken off the ventilator the first. So it is a topic that basically should be addressed by the physicians and the relatives prior to putting a patient in intensive care and utilizing a tremendous amount of dollars being spent in intensive care when a patient's condition is considered chronic, and also in addition to that, it's irreversible. But also, I think the healthcare professions, as healthcare professionals, we need to educate our patients and the relatives before that condition happens, so at least they're well prepared for it, so it doesn't become to them news when they reach the hospital. So the hospital personnel are not the ones who have to break this news. They've already been educated that you already have an advanced process here, but we will try to address palliative care, give you as much support as possible. I, for one, I do not support euthanasia, and I will not support it. But at least at the same time, if we can contribute, we have a limited amount of money to spend on health care, or else as a country we'll go bankrupt. We will not be able to have monies for our kids to have their health care looked after, and they're the future for our country tomorrow. Neither you and I will not have a health care system or health care coverage by the time we reach the age when we need it. So as a common sense approach, it should be adjudicated one by one, but I think also the physicians in general and the healthcare professionals in particular should be the ones educating those patients before the situation arises. I also think there are other ways and means that we can actually be able to save money in the healthcare industry. I think treating patients at home, addressing the pharmaceutical impact, the impact of the pharmaceutical industry in medicine, and the impact of the malpractice situation in our country. I can address those at another discussion, but that is all for now. Thank you. Today we'll continue our discourse on some of the ways and means that I think we can save money in the amount of money being spent on the healthcare industry and still preserve the United States as being the best healthcare system in the world, but it's still the most expensive healthcare system. We address the issues of trying to triage patients to hospitals and making those hospitals either hospitals for treating emergencies, urgencies, or chronic illnesses. We've also addressed the issues of basically end-of-life crises within families when we spend, and the exact figure I do not know, but it's closer to 20 to 30% of the monies being spent on illnesses is usually spent in the last few months of a patient's life, especially a patient over the age of 70. Anecdotally, I remember the article that was written that basically in the last few weeks of a patient's life, especially when they're admitted to the intensive care units or have to have medical care, whether it be from a cardiac, neurologic, or a gastrointestinal standpoint, end up having more money spent over those last few months of their lives or weeks of their life without us having a different outcome. We realized that basically prior to that person had, let's say, a month to live, but yet we continue pressing with having PEG tubes in place, CVP lines in place, blood gases done, careful monitoring done, when we know the end-of-life crisis. I'm not saying that we should not be sensitive to death and dying, but we should also be realistic. And the physician's role, the physician, especially the primary care physician, is the one to advise basically to the relatives that it is much more important for the person to be palliated and be comfortable in death and dying, rather to have all sorts of invasive procedures that end up costing the healthcare system a tremendous amount of money, especially when that money is not being spent by the private insurance carriers, but are now being spent by Medicaid and Medicare. And also when the hospitals are the ones that benefit from these enormous amount of expenses, and the healthcare industry, the healthcare system of our country is being stressed to such a degree. But it's not contributing anything towards the workforce, towards the economy, because we knew at that point in time that that person was not going to have a reversible situation. I'm not advocating that we abandon our parents or relatives. I've had the situations of having to make decision on my very father as to whether or not I think that he should go for advanced care when I already knew that he had a terminal illness. So having been that role before, I'm still requesting that physicians as a whole be the ones to tell their patients about death and dying long before it occurs. Other ways and means that I think that we could save money in the healthcare industry and at least be supportive of our president in terms of trying to get that bill passed is basically the impact of the pharmaceutical industry. There are lots of new medications that actually came out into the United States that a lot of our patients have benefited from. And I will forever be grateful to the pharmaceutical industry for them, how they've made our lives as physicians easier by being able to come up with new medications that were able to treat disease conditions at a better level in terms of some of the complications we face with in terms of the patient's condition. But I've also known cases, an enormous amount of cases, where we've actually expended so much money in the past on medications that cost 5 to 10 times as much as medications that would not benefit, that would not be different from a generic medication that has worked for the patient in the past. We should try not to be influenced by the pharmaceutical industry, especially for medication that works for our patient. We should try and at least be cognizant of what the cost of that medication we prescribe. I am not saying that we should not try a medication if your patient is complaining of a symptom, but if we've tried it for a month, 2 months, and it's not working, there's really no reason to continue prescribing that medication. Because who benefits? It's the pharmaceutical industry. But the healthcare system as a whole is being deprived of that income that could have been spent elsewhere on primary care for patients who did not have money to pay for their very own generic hypertension, diabetes, or high cholesterol medication to prevent them from being admitted for cardiac condition. make accessibility to healthcare more for those patients who have a bronchitis and not for later hours in the day to be seen by a physician, rather than missing days off work for the following day for something that they had to stay in the emergency room for almost about 24 hours before being seen. A common sense approach to the practice of medicine is what we're looking for. If a medicine is not working and the patient is saying it is not working, there's no reason why we should continue with that medication. We should also look at the medications we're using. Is it better to use a beta blocker, which is much cheaper, that is non-generic, than go for a generic one just because instead of using it twice a day, the patient is now giving to use it once a day. But it's costing them 10 times as much now to use that medication. Memory loss, which we know, in the majority of cases that I have been privileged to see patients with memory loss, and you've asked to prescribe this medication that was advertised on TV, you're having no change in the patient condition, yet I've seen physicians prescribe it time and time again. To whose benefit? Not the patient. To whose benefit? Maybe the pharmaceutical industry, maybe the special interest groups. There's nothing wrong in people benefiting from the entrepreneurial spirit of the United States of America. But in a situation in which we're faced with, in which we have limited amount of monies to be spent, let's at least try and spend that money to exactly the place where it's going to count for most. Where I think, having practiced primary care for 25 years, I found it that the money could be saved is most like in trying to prevent the onset of disease processes, trying to prevent patients getting into hospitals as emergencies, trying to provide health care for longer periods of time when patients are finishing work, so at least they do not go overnight with conditions that get worse and then present from something being urgent now to being emergent. So my thing in this, there's roles to be played by the pharmaceutical industry in developing new medications, but also the drive and the push for medications that have shown not to be helping patients should actually be, there should be a cap on the number of times you're allowed to do this. I know the influence of the pharmaceutical industry in doctors' offices have decreased tremendously, but I think we can also be able to save tremendously more by the physician being aware that the cost of medication is also driving up the cost of health care. And we should try and think within the box of containing health care so we can be on board with our President and the rest of the Congress as they try to pass a health care reform bill. Thank you. That's all for now. We'll continue our discussion on trying to save money in the healthcare industry. And these are just some of my suggestions, but there are suggestions by a lot of my colleagues when we're trying to discuss how we can try and save. We mentioned in our previous talks trying to make hospitals more specialized in caring for the emergencies and the urgencies and the chronic care. We mentioned also trying to contain the cost of doing special imaging studies, and I think the Congress actually did something that was tremendous, which is actually to say that these expensive tests should actually be available. Or if I had an MRI done for my lower back 3 months ago, and I'm now having the same pain without any further neurologic deficit, meaning it's not radiating elsewhere, there is really no great impact or need for me to do another MRI. If, however, I'm having fecal incontinence, I'm unable to keep my stool or even urinate, then obviously there's an indication for having it done at that stage. But having it available to all healthcare personnel, I know it's got to be HIPAA compliant at some point in time, but it has to be such an expensive test that it should be made available, especially if a patient had a cardiac catheterization and now presenting with chest pain and in the emergency room. I think we should have those expensive tests online where you're able to access it. However, again, here is the confidentiality of information and how information is shared. And here is where the lawyers, the politicians, the healthcare professionals need to come together. Is it so important for us to safeguard that information of having a cardiac evaluation done on you? Or is it more important for you to have that result available when, in fact, you deal with death and dying? I think the law that actually controls this, I'm no expert in the law, I will never be. But I think when you're faced with death and dying, You're faced with a life that could be saved. You're faced with also a tremendous amount of money that could be saved, especially if something is repeated there soon thereafter and costs a tremendous amount of money. And there must be some ways and means that these things have to be evaluated and be decided upon, that in cases of illnesses, results of things that are basically not considered confidential enough that someone could be using it against you, that basically should be privileged information given in a privileged situation. So expensive tests should be made readily available. So a patient who has had a previous CAT scan of the chest and now presents with something like mild shortness of breath, that CAT scan should be made available either online or by the services available while the patient is in the emergency room. Also, a patient who has had an MRI done before for persistent pain in the hip now comes in back 3 months after with a persistent pain, with worsening of that pain, should not have an MRI done immediately unless you've tried medication. But you should be privileged enough to have the MRI results when that patient is seen in the emergency room and not have another physician who's in the emergency room order another MRI for that patient. That is going to cost the healthcare system $1,500. It's going to cost them totally, by the time that patient leaves the institution, probably close to $5,000 to $6,000 for having spent time in the hospital. So I'm saying that the expensive tests should be made available for all of us to be able to view them and not having them repeated just because the patient is complaining of the symptom, when we know that the patient is not at risk for dying, but probably will have to wait another 24 hours. It will take that amount of time to even get it approved by the insurance carrier. But here, if our aim is to save money, then we should be able to see ways and means we can do it. Also, for that patient who is bedridden and at home, we should be able, as we did in University of Miami Jackson Memorial Hospital, provide home care for that patient. We should be able to send our residents at the hospital or our physicians as well to see patients at home. It will prevent them from having to call the ambulance, especially when that patient, let's say for instance a patient who's asthmatic, who's on oxygen, who's having mild shortness of breath. If you have a physician who's able to see that person at home, the relatives can call the physician and say, my mother or father is having the shortness of breath. Do you think we should put them in a nebulizer? Do you think we should call the ambulance? Are you available to see that person now, or is it within the next 3 to 4 hours? If you find that you can rely on that person's information, then you can go there in 2 to 3 or 4 hours and see the patient and prevent that patient getting to the emergency room, ending up costing the healthcare system thousands of dollars from the time they enter there. Or a patient who's having belly pain based on constipation. Am I able to evaluate you for an acute abdomen versus chronic constipation? Do I do a rectal examination, find you have impacted stool? And do I ask you to digitally disimpact it and save you that hospitalization? It's so important that we all be given some guidelines on how to treat patients who are bedridden or home-ridden based on a simple fact of what the disease processes are. For the person who's having an excessive amount of gas but complains of mild chest discomfort without any evidence of exacerbation of a cardiac condition, should that person be rushed to the emergency room with an ambulance, have an EKG, have blood gases done, have blood work done, have an echo done, have a stress test done, then being admitted in the hospital for 3 to 4 days, running up a bill to close to $20,000 to $30,000, and have nothing changed in their diagnosis and treatment? It ended up costing our healthcare system $20,000 to $30,000. It did not benefit the patient. It did not do any change. It did not contribute to any change in the management of that patient. How often have I not seen in my practice with similar patients with similar conditions? If in fact that patient is worsened, obviously we should be able to send them to the emergency room. But I think it's safe, if for saving $20,000 to $30,000, if it costs a physician at $100 to make a home care visit, it should be done. A more qualified individual is able to make that decision is why it's important for us to try and save money on home care. The patient with a decubitus ulcer, that the pressure sore now starts to bleed, doesn't need to be rushed to the hospital. That can be treated, but it needs to be examined and then treated and evaluated thereafter. It is not a reason for us to get an MRI done for the bone to see if there's or a bone scan done to see if that acute ulcer or that pressure sore now has invaded the bone. What happens now, that patient ends up in the emergency room. The resident sees the patient, decides, oh, it's close to the bone, it's on a pressure point, let's get a bone scan done, let's get a complete workup done, let's get urinalysis done because she has a low-grade fever. We end up costing our healthcare system thousands of dollars for something that could be very well easily managed at home by a trained physician or a trained registered nurse or a trained nurse practitioner or physician assistant. Those are some of the ways and means we can try and help to save some money in the healthcare industry. Thank you. That's all for now. With the present economic downturn, I've started to notice an increasing number of patients in my practice presenting with, doctor, I've started to use alcohol a little bit more frequently. I've started to smoke when I stopped smoking 2 years ago. I've now noticed that my child who is in college or who is in high school, I find their behavior a little bit different. They are much more relaxed, but they don't do their work anymore, and I think they're on marijuana. I've also found the complaint of my child seems to be on cocaine, because at times the behaviors goes up and down. What I'm alluding to is that we found in our practice an increasing number of patients, when faced with the economic situations that we have today, are turning to drugs. Unless we understand that some of the understanding out there that some of these drugs have no side effects on us, then we're missing the bigger picture. For instance, a lot of us will be aware of the common drugs that we see, alcohol, tobacco, but there's also cocaine, ecstasy, heroin, ketamine, meth, prescribed drugs, prescribed medications mixed together, over-the-counter, and steroids. The ones we commonly see in our society that I can describe and basically assure you that abuse of it is probably to your detriment rather than solving the problem. Let's, for instance, address the issue to do with the increased incidence we're facing now with tobacco abuse. The chronic smoker tells you that when I do not smoke, I feel jittery, I feel I can't function, I can't focus. That may very well be true. It's not a bad explanation because nicotine is a stimulant, but it's also a very addictive stimulant. But the raw facts about it is tobacco use is the leading preventable cause of death, disability, and disease process in the United States. I'm quoting from statistics between 1964 and 2004 that says that cigarette smoking caused an estimated 12 million deaths, including 4.1 million deaths from cancer and 5.5 million deaths from cardiovascular disease. An alarming statistic if you can actually say that it's a leading preventable cause of disease, disability, and death. It leaves us with no option that we should find an alternative to cigarette smoking. And we cannot turn to cigarette smoking as a means of relieving our symptoms or assist us in being able to function. Because if we're going to become a statistic, we can become one of that 12 million deaths from it, or 4.1 million deaths from bronchogenic cancer. When you smoke, the smoker inhales the tar or the nicotine, which actually causes the dopamine in the brain to actually be stimulated, and you feel as if you're excited, or you feel good, or you have the drive you want to function. That is the role of the stimulant. But in addition to that, when we inhale it, we inhale about 200 hydrocarbons, including carbon monoxide, and that in itself, when we inhale it, that is what causes, if we inhale it, it goes down into the bronchus. That is what causes the damages to the lungs. Initially, it causes damage to the alveoli of the lungs and basically destroy them. So instead of us having nice, good lungs that are well aerated, we have this large, voluminous lungs that are not well aerated. We start to suffer from mild shortness of breath that becomes increasing shortness of breath. But in addition to that is that the bronchus or the main airways actually become the focus of common causes of cancer. Also, in addition to that, it accelerates the process of coronary artery disease and basically causes us to have premature death from heart disease when we actually become chronic smokers. So we get the relief that we need because we're able to function. But nicotine addiction in itself causes a diffuse disease process to your blood, to your arterial system. Not only does it affect the coronary arteries and increases the risk factor for heart attacks, it also decreases the blood flow to the carotid heart arteries, hence increasing the risk of stroke or narrowing of the carotid arteries, which decreases the amount of blood flow to the brain. So it is a stimulant at that time, but it's not the fact that something is wrong with the stimulant, but the fact of what the damages from chronic tobacco abuse does to us. And the secondhand smoke, meaning breathing in from someone else, is equally as significant in causing the side effects of the damages to the lungs, the damages to the heart, also the increased risk of nasopharyngeal cancers, bronchogenic cancers, also prostate cancers, and urinary bladder cancers. So tobacco smoking as it is, which is a very, very common habit in our society, and which is one that I've noticed in my practice that the patients I'm seeing are starting to increase the abuse of, should be something that should be discontinued at all costs. Another fallacy that I hear is that a parent comes in, brings in the young adult son, most commonly, daughters are now included as well, that my child is smoking weed, or Indian hemp, or ganja, or Mary Jane, or whatever name you want to call it. Is there a risk for them? The teenagers believe that there is no risk. But studies have borne it out that when you take it, it makes you relax and you feel good. But a person who starts as a teenage smoker is more likely 50% of a chance to end up needing depressive medication as they get older. Or the increased risk of schizophrenia, which is a disorder of thought, emotion, memory, and perception that is a lifelong illness. So starting marijuana smoking because it's cool, because it makes you feel relaxed, because it makes you feel as if you want to manage your situation better, because you don't have to confront the world as you see it, but also because your friends are doing it, is a habit that should be discontinued. And it is a dangerous habit as well. The active ingredient of marijuana, THC, or tetrahydrocannabinol, is dangerous for us to use on long-term basis. I've heard patients say, but I only smoke a joint per day. The chronicity of it and the long-term usage of it definitely affects you in the long run. It helps you cope with your situation now, but so does exercise, so does going to your religious organization also, but it doesn't have the side effects as marijuana usage has. So my instruction to you is that regardless of what your friends tell you, marijuana usage increases the risk factor of suicide, depression, and schizophrenia as you get older. So it's not a harmless drug. I've also noticed in our community an increased usage of steroids. And I've seen a patient quite recently who has actually been the victim of steroid use. He looks well pumped up, but he's damaged his liver. He's now been diagnosed with a liver tumor. He has testicular atrophy. He was able to build a very nice body, but what he has damaged to himself includes cataract formation at an early age. Makes us want to discontinue those persons who go to the gym and use steroids and think it's harmless, or just use it for the sake of building muscle. In our community, I've also noticed an increased usage of cocaine, but I'll address the side effects of cocaine and ecstasy in another topic. Thank you, and that's all for now. One of the more common presenting symptoms in family practice that I see in my practice at Richmond Hill has to do with headaches, patient complaining of, doctor, I've suddenly started to have a little bit of headaches, dizziness, malaise, lassitude, some non-specific chest pains, and I'm feeling tired and easily fatigued. I'm not able to focus as well. I'm not functioning as well in my job. And the symptoms can go on and on, but there's similar symptoms that have no focus in terms of what organ system. When you're faced with such a patient, sometimes the physician goes through a cursory examination. And in that cursory examination, you try to elucidate as best as you possibly can what do you see in that patient to help and to contribute to a working diagnosis as to probably the three or four most common causes that could make that person. And here again, you try to stratify it based on the patient's age, based on the patient's premorbid conditions, the medications they're taking, the disease process, or in addition to that, other mitigating factors in their life, acute stress, etc. Let's take, for instance, our young physician again, Pawan, and basically say he presents with headache, dizziness, tiredness, and fatigue. And let's say he was more or less an older person on chronic medications and who has multiple symptoms from either hypertension, diabetes, coronary artery disease, etc. Our examination for this gentleman or lady presenting with those symptoms of headaches, malaise, lassitude, inability to concentrate, feeling tired and fatigued, and we look at your face, because you cannot come to a diagnosis by saying, oh yes, you have this. You have thyroid disease, or you have heart disease, or you have lung disease, or something is going on with your gut, or I think you have a brain tumor. Because none of those will be correct, give and take what the situation is. But this is a common presenting complaint in family practice. Looking at the patient's face, as a physician who's been in practice, you look and see at the patient's demeanor, you look at the hairline, you're looking at the eyebrows, and look at the hairline. He doesn't have a forward look on him to suggest that he is anxious, depressed, worried. He's got a full head of hair, no premature graying, no receding hairline, basically suggests things like lupus. His eyebrows are basically normal eyebrows without being overly thin to suggest thyroid disease. We look at his eyes. He's got normal eye movements. So far, blinking is appropriate, not too much blinking, not too little blinking. We're looking at the pupil size. That looks essentially normal. But even without a light being focused on the patient eye, let's say, for instance, we look at the eyes now, and we're basically looking to see whether the sclera is pink or pale. If it is pale, we assume it's anemic. If it's pink, we assume that basically the patient is well nourished. We also look at the periorbital areas to see whether or not there's evidence of chronic sinusitis around the areas of the eyes, whether or not there's any lateralizing signs with eye movements, to see if there's any evidence of compression of those cranial nerves that actually innervate the eyes, which is the third, the fourth, and the sixth cranial nerves. By asking him to move his eyes from side to side and follow my finger, I can actually see that all his eye movements are normal, and I can actually rule out those cranial nerves. But what I'll try and do is to do it systematically, a cranial nerve examination that we can do with a patient that presents with the same symptoms, because it's mandatory at the end of our examination to at least make sure that all his cranial nerves are intact, especially for a patient presenting with headaches. And we looked at his nostrils, evidence of fullness of the face, to say localized tenderness, for evidence of either an infective process going on at the time. We look at his ears, his parotid gland, no evidence of any enlargement of the parotid gland. We can look inside of his ear for evidence of infection, evidence of impacted wax that can cause dizziness, in addition to the mild headaches that you can sometimes get from just acute sinusitis or chronic sinusitis. We can look at his face, among his lips, for evidence of pink around his lips or evidence of central cyanosis. Usually if we look around his lips and it starts to have a blue discoloration, it makes you wonder whether or not that person has got either cardiac disease or a pulmonary disease that is causing an decreased amount of oxygenation to the blood that now presents with peripheral cyanosis. That is much different from that is central cyanosis in itself is a disease process that comes from long-term mismatch of oxygen and carbon dioxide in the blood that results from several forms of heart disease, including valvular heart disease and also things to do with congenital heart disease itself. We can also establish whether or not he's got evidence of lung disease and aeration of his lungs itself. We look at the gentleman's neck itself. Suppose he was an older person as it is, for evidence of jugular venous distension. We also can look for any evidence of wasting of the sternocleidomastoid muscle, which also indicates evidence of accessory muscle involvement. We can also look at his neck and see whether or not the thyroid gland itself is enlarged or within normal limits. This same patient who presents with these symptoms, if you were to try and evaluate in terms of cardiac disease presenting like that, will involve examination of his chest, examination of his lungs, and I'm going to try and do that in our next session. In addition to that, having an EKG or an echocardiogram will help tremendously in terms of honing down your diagnosis, whether or not this headaches, dizziness, shortness of breath, malaise, fatigue is actually related to either cardiopulmonary disease, whether or not it's related to anemia, whether or not it's related to things like jaundice. A lot of times we get asked by patients, doctor, I feel as if I have jaundice. But jaundice, when you look at this gentleman's sclera, you look at the sun-exposed sclera. You ask him to look to his toes, and then you look at the look to your toes, and the non-exposed part of the sclera is evidence of where we can find evidence of jaundice, and that's when the discoloration appears yellow. And then you can make the diagnosis of jaundice. What is jaundice? Jaundice is just the waste product of bilirubin that comes from it's a waste product from the bile duct. That actually is from the metabolism of the bile. In a patient with evidence of jaundice, it means that bile does not empty from the common bile duct, and the gallbladder does not enter into the gut. So there's some level of obstruction. That obstruction can either be within the biliary tree, within the liver itself, or can be distal to that. That in itself is another topic that we can get into, but it's commonly asked by patients, doctor, I feel as if I'm jaundiced, or I see my eyes are becoming increasing yellow. So in trying to elucidate the common symptoms that we get as physicians with dizziness, fatigue, and non-specific symptoms, it's always important for the physician to be the one to be able to have a high index of suspicion as to what are the common causes that can present like this in a patient. But at least at the same time, you have to be able to stratify what are the patient risks. It is in your best interest, if that patient is a patient of your practice, that you're able to make the difference from what that patient's prior to the complaint was to what their complaint is as of today. That is all for now. Thank you. Good morning, viewers. This morning's topic will be one of several parts. We'll try and address the issue of weight and some of the social and medical problems created by the increased weight. Most of us who grew up in Guyana and the rest of the Caribbean were fed on a diet that's extremely rich in carbohydrates. Example, the rice, the flour products of roti and bread, the ground provision, etc. We also grew up with the concepts that fat is nice, and being skinny means that you're in ill health or not so well. In the United States at present, we're involved in an endemic of mammoth proportions based on the obesity problem. The obesity, as it is not only an adult problem, it's also a massive problem within the schools, and most of us would be privileged to listen to some of the views and the problems that are being created by obesity in our schools, in our workplaces, in our working environment. So important is obesity that the body mass index, which we can easily get a table of by just Googling BMI or body mass index, is going to give you an accurate, or as accurate as possible, a guide of what your ideal weight is for your height. For instance, if you take a 5'6" individual, the body mass index at a less than 120 pounds will be 18.5. Between 18.5 and 24.9 BMI is when someone of 5'6" weighs less than 150 pounds. That will be considered the ideal weight for that person. So just imagine our family members at 5'6", weighing less than 150 pounds with medium body frame. Most of us will not be in that category. So most of us will be considered overweight if at 5'6". I'm just using 5'6" as a parameter for us to remember. Over the weight of 150 pounds, that person is considered overweight. Up to the weight of 180 pounds at a 5'6" individual, that person is then considered as being obese. Obese is not just a description of that person's excess weight. It also, when you express a BMI of greater than, let's say, 25, then we are prone to disease processes being premature in us. And these are some of the things that we as a people are prone to, which is the diabetes, the high cholesterol, and the resultant coronary artery disease, and the increased incidence of hypertension at a much earlier age. So when we look at that table, we should put our height in, find our weight is, and then try and calculate. In excess, when we actually are considered obese, that is when we can actually figure that we will be getting this premature risk of these diseases, especially if we have a propensity for the development of them in our family. Some of us might say, well, if I'm a muscular individual, then I'm expected to weigh more. That is true, because muscle weighs, say, a little bit more than fat, but not significantly so. So that is really not an argument. Once we understand that obesity is not a bad word, but it's a warning sign for us to take care of our health and try to alter our lifestyles, alter our eating habits to make sure we approach the BMI, what is considered average for us, which is between 18.5 and 24.9. And your physician should be the one who tells you what your BMI is. Waist circumference is one of the other parameters that we sometimes use, and it's just measuring your waist size, or you can actually measure your pant size. Here again, you're not measuring your hip size, you're measuring your waist. For a man over 50, it's considered severe risk of disease associated with obesity. For a woman over 35, it's considered. In the next topic, I will try and address what are some of the risk of disease and disease conditions associated with obesity, how we can assess those of us who are at risk, how we can try and treat those who are at risk of developing these illnesses, and what are some of the treatment alternatives that we can use. That is all for now. Thank you. Good morning, viewers. We will continue on the topic we started with last week regarding obesity and weight management. We discussed the topic of body mass index and how we classify it, waist circumference, and how it affects us. What are some of the risk factors and the risk of diseases and conditions associated with obesity? Because when your physician describes you or describes us as being obese, whether it be mild, moderate, or severe, or actually describes our condition as being underweight, average, overweight, it must be put in light as to what are the coexisting conditions that we as individuals have that makes obesity or overweight a greater problem for one person versus the next. For instance, if someone is overweight with no other coexisting condition, meaning hypertension, diabetes, heart disease, habits of cigarette smoking, lack of exercise, they are not as much risk as the person who is overweight with more than one coexisting conditions that actually make your general health much worse. Now, what do we really mean by this? Let's take the individual who has got a family history of coronary artery disease, who is diabetic, and who also has hypertension. His risk, when you add obesity or even overweight to his condition, he will quadruple his or her risk factor for heart disease. So when we consider our weight, we're not considering our weight in a vacuum. We're considering our weight with our underlying unique disease conditions. High blood pressure, in addition to the obesity or in addition to overweight, which is when we classify as overweight being your BMI is over 25, and I told you how to get your BMI by going in the computer, Google body mass index, and you'll get that table, and you can actually do it for yourself and family. If your parent, your father, mother has high blood pressure and diabetes, then you must not make them overweight. You must insist that they try and maintain the average weight. You also insist that your kids at an earlier age should actually try and decrease their body weight, especially if they happen to be overweight, and if there is a history, as we all have so common in our families, diabetes and hypertension. or high cholesterol. So those of us who are increased risk for being overweight is the conditions of high blood pressure, high cholesterol, or the bad form of cholesterol being higher than usual, the good form of cholesterol being lower than usual, and the triglyceride being high. For those of us who have increased fasting blood sugar, whether or not we've been diagnosed as overt diabetics yet, for those of us who've had a family history of heart disease, whether it be stenting, whether it be coronary artery bypass graft in a brother, a sister, a father, a mother, those of us who are prone to physical inactivity, either by choice or by the works that we do, the jobs, occupations that we do, and some of us who choose to smoke cigarettes. The assessment then is made of what is the BMI of that individual along with the coexisting conditions. If we can have those, then we can stratify our risk and tell our physicians, at least be part of the discussion of our health in our overweight, our obesity, and how it will affect our life expectancy. That is all for now until we resume this topic on overweight, obesity, and coexisting clinical conditions. Thank you. Good morning, viewers. Let's continue our topic of discussion on obesity and its complications and its effect on our organ system and disease processes. The last two topics we concentrated on the BMI and how to predict our risk factors. We also discussed briefly why is it become increasingly important as we develop disease conditions to consider our weight much more seriously than if we did not have disease conditions. Why is obesity and overweight such a great problem for us and such a difficult problem to manage? Lots of times in my practice on a daily basis, I'll hear the comment, Alvin, myself, yet I keep putting on weight. I can eat one slice of bread per day and yet I see the fat coming on. Or it doesn't matter what I do. I've been exercising every day and yet the fat remains. We must understand then how is it that fat becomes distributed in the body. If we look at this diagram, it shows us when cells are growing, when the fat from the blood vessels actually get deposited into the cells that make up our entire body. Then they get distributed into those cells. Then they start to take over those cells. And that now becomes a full-grown fat cell. Even if we end up losing weight, that fat cell is going to persist for life. However, the quantity of fat in it will be reduced. So for all intents and purposes, it's in our interest to lose that fat. Fat in itself is not totally absent from the body. In the average male, 10 to 15% of your body mass is fat. In the average female, it's about 20%. So it's a natural part of us. When we run into problems is when that 10 to 15 or 20% becomes 30, 40, and 50%. That is when we actually create disease process for ourselves. If we look at what the normal fat distribution in the average person is, it's mainly over the abdomen, the belly itself, that we tend to put on the weight, and on the legs itself. In the buttocks area towards the back, the same thing applies to females as well, but more so in the buttocks and the abdominal area and the upper thigh areas. Those are the ones that we develop the fat deposits much more common, and also under the area of the breast as well. But they're also the most difficult areas to lose the weight based on the simple fact it's very difficult to exercise those parts of the body. If in fact we were to have a distribution on the limbs itself, by vigorous exercise we can lose those rapidly. Hence, the best method of us preventing it is trying to avoid it and to be able to eat healthily and understand what the portions of food that we eat and how much we need. For instance, the average glass of alcohol, of a 1 ounce glass of alcohol, is almost 100 calories, yet we can consume a significant amount of those. The average amount of rice that fits into my hand is literally almost about 300 calories. Most of us will try and consume 4 to 5 of those per meal. To understand that the size of a roti can actually give you 250 calories for a medium-sized roti, a larger one will give you a lot more. Same for a slice of bread. So you must be aware that the quantity of carbohydrates per meal should literally be fitting into your hand and not heaped up on your hand, but just flat on your hand. It's not just because we talk about the quantities we eat because we think it's just going to cause the abnormal distribution of fat. But look at what happens at a cellular level, which is so important for us for prevention of heart attacks, prevention of stroke, which are the two biggest disease processes that we are faced with when we actually develop these infiltrates of fat within the blood vessel. Let's take this blood vessel for argument's sake. This is the lumen of the blood vessel through which the blood flows. When we have fat deposits, those fat deposits actually occupy a greater portion of the lumen of the opening of that vessel and causes it to be narrowed. Addition, if you imagine you're going to add cholesterol deposits to this as well, you're going to make it even narrower. So just imagine that this is the blood vessel that actually supplies your heart. This is the same blood vessel that supplies your brain, your kidneys, etc. Now because these deposits, we narrow the amount of blood that's coming to it. We decrease the oxygenation, which is the oxygen that's carried in the blood. So this is a phenomenon that's occurring throughout the entire body. Hence the reason why obesity, the fat deposits become such an increasing problem for us at a vascular level. It's not only the fact that it probably sometimes can look unattractive, but basically in terms of how it supplies our vital organs. For instance, just think about what happens on the outside of the heart now. This is a heart in which we have deposits of fat around it. This is now covered with fat, but basically the biggest issue for it is not this covering of fat that we can sometimes see on postmortem specimens, but what happens with the muscle of the heart itself. Now it's not only muscle. You can see these yellow spots. These are what fat deposits does. And these fat deposits now prevent that previous functioning organ, which was contracting and expelling the blood very efficiently, now to be not able to do it because the muscular function is compromised by the fat deposits. That in itself is not easy to lose. My pitch to you is that basically if we try and prevent it, prevent obesity, prevent our methods of eating, and try and decrease our weight gain, we probably can be in a much better health condition to enjoy the rest of our lives. Thank you, and that's all for now. Good morning, viewers. We will continue our discussion on obesity and complications of obesity. In response to some of my patients who have actually been seeing our program on obesity, there are some questions we should clarify. For instance, one woman asked me, Dr. Valdeo, my parents have been over, both parents have been over, considered obese, and yet they live to have life expectancies of greater than 70, greater than 80. My father, who was big and fat, he lived until he was 80. Yet my skinny brother died of a heart attack at 40. So is obesity all that bad? It's not that obesity isn't bad. It's the disease processes associated with obesity that creates the increased risk factors. God bless our parents if they can live to be 100 being obese. The issues we face with obesity increases comorbid conditions, increases the risk for disease conditions of hypertension, diabetes, coronary artery disease. So if we can prevent them, that's our aim. If we are going to be living a long life, regardless of the fact if we're obese, the fact of our life expectancy being affected by our weight is much higher. For those of us who have got very good genes without other disease processes, obesity in itself is not going to be as important as those of us who are at risk for these disease processes. What are some of these disease processes that we know of and as well documented? For most of us, as we become obese, we lose our self-esteem. We start to think of ourselves as being as unattractive, or our partners think of us as being less attractive, and sometimes comments about it. We have an increased incidence of fungal deposits within the skin, increased incidence of infection of the hair follicles resulting in impetigo, sometimes increased incidence of having acne formation of the face. The cardiovascular system is affected because of the increased fat deposits within the coronary vessels, which increases the incidence of small vessel disease to the brain, which results in a stroke, with the heart itself, as we discussed in a previous topic, where the vessels themselves be compromised and decreasing that blood supply that goes to the brain and to the heart itself. Also, in addition to the legs, the blood supply to the legs become diminished. We start to feel increasing tiredness and fatigue within our legs. Due to the fact of the increased amount of fat cells, the heart has to pump against an increasing resistance because the fat cells themselves start having smaller blood vessels, and the heart, now having to pump that blood through those blood vessels, has to pump against an increasing resistance, hence the fact why we develop hypertension with obesity. It's not always as simple as that, but that is the way that the majority of cases are actually, most of us will develop. In the case of diabetes, because we produce a certain amount of insulin on a daily basis from our pancreas, when we increase the number of cells within the body by the additional fat cells or the increase in size of the fat cells, it creates a relative insufficiency of insulin. We do not get enough to the cells, hence some cells have a high blood sugar level, hence we become diabetic because of the increase of blood sugar, because our insulin being produced by the body, if the body was supposed to have, for argument's sake, 100 cells, now it has 150 cells, it's going to be a matter of supply and demand. We are unable to supply that, hence we become diabetic. But more importantly is for some of us, if we develop insulin resistance, which means now we cannot just be treating our diabetes but with diet, exercise, and medication. Now even the insulin that will be taken will become resistant to that. Hence it's important for us to understand what are the long-term sequelae of us trying not to control our eating habits, so make sure we do not develop diabetes itself. In addition to us, sometimes when we put on the weight, we compromise the lungs. We have difficulty breathing because when we sit, the lungs themselves become compressed. Or most of us will know this, the effects of the joints, especially the joints of the hip and the knees themselves, from the increasing weight. We also know that we can develop flat feet, calluses on the legs and calluses on the feet themselves, and also swelling of the leg. Also, in addition, there's an increased incidence of gallstones. Those are just some of the complications of obesity. Let's try and prevent them. That's all for now. Thank you. Good morning, viewers. We will continue our discussion on obesity and the complications of obesity. For our kids who are computer savvy, Google body mass index, print out that table on body mass index, and assist your parents and grandparents in taking care of their own health. When you have a table that gives you the body mass index, which is basically very simple, on the y-axis you will have the height, and you just go across and find the weight of your parent, grandparent, and see where their BMI is. If their BMI or body mass index is over 25 and they have other health conditions of hypertension, diabetes, then it is important, it's imperative for you to address those issues with their doctors. If it's over 30 and they have one condition and they're younger with hypertension, diabetes, or high cholesterol, here again their weight has to be reduced to decrease the risk factors we face with. So if in fact your kids are computer savvy, just to print that table out could be one of the earliest and the easiest methods of controlling your own health. It can be even done as a family project together in finding out who is overweight, what are the risk factors you face with your disease conditions. Because it is so important for us to treat obesity not as if it's just fatness, but obesity equals disease processes unless treated. If we can assist our parents to live longer so they can take care of our kids for us, we can get a better life. Having them around is also a credit to us. So just by simply addressing the issue of their weight with their disease condition, by just getting that BMI index done is much more important than just actually telling them to lose weight. Because they will tell you they've been dieting from agnosia and no help in terms they exercise, they go for walks. But here again, there's much more in terms of that. First of all, evaluate where they're at. Discuss it with their doctors, whatever the risk factors they're faced with coexisting conditions. Decide how you can assist them in terms of their diet and exercise. Quantify the amount of calories that seems to be in the food that we commonly eat. Here again, a simple parameter that I've used in my office is asking patients the amount of carbohydrates in the form of either roti or rice should not exceed a palm full, which is flattened, not elevated, per meal. Your last meal should not be 4 to 5 hours before you go to bed. You should desist at all times from eating anything that's sweet, whether it be pera, parsad, sodas, Indian sweet, West Indian sweets, especially if you're trying to lose weight. You also should try and eat a fruit per day, one fruit per day, preferably an apple, which has enough fiber, it has enough calories. Avoid eating things like cherries and avocado, cherries and watermelon themselves, which are really just sugar water. It tastes good, but at the same time, it's got the caloric intake is going to increase the amount of sugars that we expose on a daily basis. So we've got to be sensible in terms of what we're eating and try and decrease the quantities that we're eating. Also, we can try and quantify the amount of exercise that we're actually able to do. If we're able to say that we can do pushing a trolley with our kid inside of it for 30 minutes is cardiovascular exercise to lose 200 calories, or taking our parents for a walk for 30 minutes in a park and a brisk walking. Those are some of the things we must be able to quantify and say how much of it we can actually be increasing to increase the amount of caloric expenditure, and hence in fact try and decrease the weight. It's all a matter of supply and demand. If we oversupply it, then we're going to be putting on weight. That is all for now. Thank you. Good morning, viewers. This morning's discussion will be on workers' compensation insurance, workers' compensation case. When a person gets injured in the workplace or at the workplace, that incident, whether it be an injury to the lower back, to the legs, to the arm, is reported to that person's supervisor, who then writes an incident report, documents the injury, and advises the patient to be seen by a physician for one, diagnosis, documentation of the injury, and also to decide whether or not that patient will benefit from medication, time off, therapy, etc. That's a clinical opinion. What is important is for the employer to document the injury and report it to their workers' compensation carrier insurance company. In that case, the patient is then covered for a work-related injury to that part of the body that has been affected. Workers' compensation insurance in our community seems to be slated with a couple of taboos. Taboos in terms of, am I going to be discriminated by my boss because I report a work-related injury? Am I going to get paid? What are going to be the long-term implications and sequelae of my injuries? Those are not difficult things to answer. Once my practice in Richmond Hill caters for a large portion of the Guyanese and a broader cross-section of the West Indian community who have work-related injuries. It doesn't form the majority of my practice, but it does form a significant portion of my practice. But I think there are things that have seemed to be common that I seem to encounter. One, patients feel as if they're going against their employers once they report a work-related injury. That is not so. And it really does not affect the employer, neither does it affect you. What it does is protect you from long-term sequelae of that particular injury. Because now if you have a documentation of that injury, the employer or the insurance is responsible for that injury for the rest of your life. Your major medical insurance will not pick up that as being part of a normal condition. They'll say it's a pre-existing condition. For one, it's important that you actually use it to make sure that you get the best possible care. If you get well, then obviously we will all get back to work because we need to work. If, however, it becomes a permanent injury, that is what makes it more significant for you, because you've reported it, you reported when it occurred, it's a legitimate injury, it's recognized both by your employer and yourself that it is a legitimate injury. Workers' comp is not an insurance or that is fraught with abuse, but it can be. So that's why you need to make sure that your injury is, one, reported, two, the physician examines it, writes a report related to that injury, gives you medication, starts you on therapy, evaluates you, and if there's any adjunctive care that needs to be given, whether it be physical therapy or chiropractic care, let the MD, let the doctor be the one to recommend it. These are not things that actually can be recommended by chiropractors or physical therapy places. It has to be documented by a physician as to the exact nature of your injury and what he intends to do about it, and how he intends to evaluate it, and how he intends to make sure that that injury is not one subject to abuse by you taking time off to fix your house or going on a vacation. It is a serious insurance that should be treated seriously, but the documentation by the physician and the physician's practice is so important to you that if it's not documented properly, one, you will not get the payment you deserve because you're out on a work-related injury, or you will not be protected because the case was not covered properly from the inception. There is quite a bit of paperwork that needs to be done. My office can be a resource in terms of assisting you, in terms of educating you what needs to be done, so at least your case does not become messed up from day one. Workers' compensation insurance is a broad topic. We'll resume this conversation on another day. Thank you very much. Good morning, viewers. We'll continue the discussion on workers' compensation insurance. The last time we left off in terms of the importance of having your physician be the one to document it and have the reports ready. The paperwork has to be done appropriately and correctly and be submitted on a timely basis so that your payments for your salaries continue and you're not left in the cold having to bear the burdens of paying for your rent or your mortgage, etc. That your work-related injury, the insurance carrier is paying for that. Here again, you need to have it done properly from day one, both in terms of the registration, what is sent to the Workers' Compensation Board, what the reports are sent to your insurance carrier, etc. Now, having started treatment with your physician, who actually dictates how many times you come for therapy, physical therapy, or if there's a neck and a back injury, an adjunctive chiropractic care as well could be recommended, and whatever medications, that is documented. And for all intents and purposes, you need to be in the physician's office if you say you're going to be there. And especially in a workplace injury, because it's fraught to abuse, there are going to be people who are going to be looking. And investigators are not uncommon. So if you're legitimately injured, you should not be afraid. You should make sure you get your therapy and get the relief from your pains, documented as well by the doctor's visit, and have that as a ready, that is now becomes an important information that you will now present to the workers' compensation hearing as it continues. Here again, do not feel that this is a process that is going to be occurring overnight. Workers' compensation cases, by and large, are very common, but also in addition to that, the process is a slow one. It's not an automatic process. Sometimes it takes about 45 days to get your first paycheck that should have been due in the second week of your case. Sometimes, in addition, it takes about 6 to 8 months to even get a hearing from the judge. Here again, these are not things to be afraid of. It's a process. To have an attorney represent you is not uncommon. In fact, it should be the rule. Why is that so? The attorney is able to call the board, to call the insurance carrier, to call the caseworker, inform them as to the status of your case, inform them that you are actually taking treatment. These are the bills that were created from legitimate treatment for your injuries, and actually represent them to the carrier's insurance and also to any law enforcement authorities that this is what is the condition of the patient, and it makes it easier for you to get paid. Is it mandatory to have an attorney? It's not mandatory, but what it does, it helps to make the legal aspect of your case a lot easier. If you do have a lawyer who represents your family and is accustomed to has been doing workers' compensation cases, it makes it easier to deal with. But there are lots of times there are lawyers who specialize in this particular branch of law, workers' compensation law. And in my experience, it's always been beneficial to go with someone who's been doing this on a regular basis. Here again, the treatment and getting an MRI done right away is subject to what Workers' Compensation Board and the insurance carrier dictates, but it's based heavily also on what the physician writes. If the physician say my patient has experienced numbness down the leg from the low back injury, they're going to approve an MRI to be done for the lumbar spine. If, however, you're just getting low back pain, an MRI is not indicated. Therapy is indicated. Medication is indicated. And those are the things that are judgment call to the physician. Here again, you cannot just go to the physician for the visit and tell him that basically I'm getting numbness now, and you have not been getting any adjunctive care, whether it be physical therapy or chiropractic care, because those are cheaper things. An MRI will cost your insurance carrier close to $1,200. The cheaper the therapy that could be given, it makes sense. Those are the ones that should be given. We will resume this very complex and detailed topic called workers' compensation on another day. Thank you. Have a great day. Good morning, viewers. We'll continue our discussion on workers' compensation. We discussed topics to do with reporting of the injury, seeing your physician, starting physical therapy, and possibly chiropractic care, the possibility of getting an MRI, the role of the attorney who makes sure that your salaries are being paid, to the point where you're possibly in the second, the third, the fourth month of your therapy, and you have not been at work since, or maybe you have resumed work on a limited basis based on the fact of your injuries. What are the other things that tend to happen around the same time? Around the third, fourth month, the insurance carrier might elect to find out whether or not your injuries are legitimate. They might ask you for an IME, or what is known as an independent medical evaluation, meaning your doctor has written a report saying Mr. J has got an injury to his shoulder, to his back, and to his knee from the work-related incident, and has been having therapy. His salary is being paid. He is going for therapy 5 times a week. The physician has actually asked for an MRI to be done to see the nature of the back injury, the leg injury, and to try and find out why is it not responding as much as it should be, to see if there's any evidence of ligament tear, any evidence of meniscal tear, things that do not show up on an X-ray. The insurance carrier might ask at that point in time, let us send you to our doctor. Let me see if your doctor is telling the truth, or basically let's see if you are telling the truth. Here again, it's not a test in terms of you as a person. It is just to establish whether or not your injuries are legitimate. Here again, it's not what you say, it's not what the physician says. It's basically what is the truth. If you are in fact having pain, any physician will be able to evaluate your pain status and determine to the best of his ability if it is legitimate or not. Hence, the insurance carrier have a right to actually tell you to go and see their physicians as a matter of choice. They will be paying for that physician to be seen. What I find in our community, it creates a sense of fear when someone is asked to go for an IME. They tend to think of it, oh, is something being questioned? Nothing is being questioned. All is being asked is, are these injuries legitimate? And if in our case they're legitimate, there's no reason to fear. Inform your facility that you're taking treatment. What is it you need to do for your IME? What is it that you need to take to the other physician who doesn't know you from Tubang, to take to him and say to him, doctor, I do have legitimate injuries. Here is where I was treating, this is who my doctor is, and this is the reports. So when you go for an IME, you should be taking at least your doctor's reports. You should be informing the attorney, so at least we can get copies of the C4 forms to show that these are the bills that are outstanding or still the bills to be paid. You should have copies of MRI if you are done, and all reports that are actually issued by the physician, and maybe some from the physical therapist and the chiropractor. I will discuss in the next time I talk what an IME is and the importance of you attending your IMEs. Thank you. Have a great day. Good morning, viewers. We will continue the discussion on workers' compensation. We mentioned in the past the key players being the supervisor at the workplace, the case manager, the insurance carrier, workers' compensation board, your workers' comp attorney. And now, the last time we left off the independent medical evaluation or the independent medical examination done by a physician of the insurance choice. Here again, the IME should be attended unless there's other mitigating circumstances that prevent you from going. But even if it is postponed, it should be documented who approved the postponement of it. But for all intents and purposes, let's make sure we attend your IMEs. You take the relevant documentation with you, so at least the physician who's now seeing you for the first time knows that your injuries are documented by your physician. You have other collaborative evidence, being your X-ray report or your MRI reports. But more importantly, which is something that we in this community desist from doing, is taking a witness. Here again, your physician, obviously, you've been seeing him for a while. He is going to be your physician who documents your real injuries. He has been seeing you and seeing the pains that you've been suffering over the last 2 to 3 months or 4 months prior to you having the IME. Now you have a new physician who is being asked to evaluate you 4 to 5 months after your injuries. He has no clue as to what you've gone through over the last 4 to 5 months. He will assume now that this is a healthy-looking person, probably complaining of a little back pain, but who's fit to work. They have no clue as to what your pre-existing condition was, how the injury, the work-related injury, has actually affected you, and cannot even try and predict what the long-term sequelae is going to be for that injury. There is where it needs a physician who has been seeing you continuously to make that evaluation and to be on your side to make sure he tells the true story. The physician who is going to be doing the IME is going to be on the insurance side and saying, well, the person has actually met maximum improvement, or they've improved to such a degree they can go back to work now, or they look fine. My advice to you, as patients in general, is when you go to an IME, especially if we are not very well schooled in the United States, we are afraid to discuss our viewpoint. We are afraid of the physician in the white coat. We are afraid to even say what we are feeling. If you happen to be in that position, and even if you do not, take a relative with you, someone who's more articulate in English, and also someone who can document to the physician in the physician's office, here is the history of what I've been through. Doctor, just do not put me on a couch and ask me 2 or 3 questions of what I've been going through. Let me tell you, and be prepared to give me at least 5 to 10 minutes of your time, doctor, for me to tell you the history of my injuries and how it's been affecting me. Here again, it's not me saying I've got low back pain. I will tell you from the time I was injured how I was functioning before that. Let's just say, for instance, pain in the back and pain in the knees, how it does affect you. From the time you get to go to bed at night, you're not able to even lie properly. You wake up in the middle of night because of the pain in the back. You get up to go to the bathroom, how it affects you. Going to the bathroom, you have instability of your knees. You go back to bed at nights, you cannot even sleep properly because the pains, when you turn and twist, it affects you. You wake up in the morning, it affects your knees to get off the bed. You feel unstable about it. You go to the bathroom, you need help in putting on your pants because of the simple fact of what the pains in the back and the neck is. And these are things that you must describe to the physician. This is how this injury has actually affected me. He's not a magician, and neither is he on your side to be of any assistance to you in legitimately writing out the complaints that you've had. The physical examination is the least important of all of this. The most important thing is what you tell doctor, this is how this injury has actually affected my life. Next time I will try and be a little bit more expanded on what you need to say at an IME. Thank you. Have a great day. Good morning, viewers. We'll continue this discussion on workers' compensation, particularly the discussion on the IME, or the independent medical evaluation. The last time I spoke, I discussed with you the importance of taking a relative who probably can describe your conditions much more, especially a son or a daughter who knows what you go through on a daily basis, because a lot of times our people tend to forget what they go through. Because here again, this new physician who is now examining you and is going to write a report and send it to the Workers' Compensation Board, and the workplace insurance carrier is going to say, Mr. D now feels totally good. He is much improved. He jumped up on the bed. He basically was able to walk into the examination room. He's not aware of what you went through to the 5 months prior. Your son and your daughter, whoever is there with you, accompany you, should actually ask the physician, doctor, please